if you see, this injury happened on the 12th, surgery was excellently taken care of. And she came back, and on the 14th, again, she went for another IM nailing. On the 17th, she went for Achilles tendon repair. And the vascular surgeon thought that it was more of a microemboli problem, and no intervention was planned. And this was the first picture that I could get my hands on. And this was how it looked on the 15th. And by the time they called for the hyperbaric consult, it was the 23rd when the consult was called for hyperbaric after the Integra acellular graft was applied on the leg. And it has been 11 days since her surgery had happened, and we had to repeat the arteriogram, and we started hyperbaric therapy the next day. And despite aggressive therapy and also despite hyperbaric therapy, she ended up deciding to have her amputation done on the leg. So this was after 28 hyperbaric treatments, and because of the pain and tenderness in the leg, she decided to give up and have amputation done. Now, this was on the 23rd, the picture, if you see the discoloration, the blisters on 26th on the foot, and the blisters on 26th on the foot, and the Integra graft that was there. And if you see that the blistering increased, and if you see the picture on your right side, there is the discoloration on the ankle area with necrotic skin, and she ended up having amputation and a graft placement done. Now, what did hyperbaric do here? It possibly saved her day with this in preparation for this graft and preventing this area from getting worse. She had, if you see on the knee area, there is the black material on the knee area, and we ended up continuing with local care, but she had some reoccurrence, so she came back earlier this year, but this is how it looked. So what I want to stress is hyperbaric approach. What is hyperbaric therapy? It is nothing but intermittent, 1 to 3 times a day, short-term, and high-dose oxygen inhalation therapy. So when we do this intermittent therapy, I don't want to go completely into the basics of the hyperbaric therapy physiology, but if you see the Boyle's law, pressure into volume is a constant. When you increase the pressure, the volume reduces, and this law works when there is bends or when the deep dive is done and the patient come out and there is bubbles in the system. Or when the artery, even occasionally when there is arterial injection of the air, that happens and people die and we don't know why. So, and possibly this is the only time when it is very much applicable that Boyle's law works in that scenario. Of course, the most important law for crush injuries are in people with this kind of presentation is Henry's law, where there is the gas that is dissolved at a constant temperature is in direct proportion to the partial pressure. So if you put a patient in the hyperbaric chamber at a constant pressure and increase when the temperature is normal, there is increased diffusion of oxygen into the tissue. So acute traumatic ischemia, compartmental syndrome, threatened flaps, and burns and frostbite could be combined into acute traumatic ischemia. Now, what is the common factor in all these? The common factor in all these is the ischemia that happens, and also the rationale for this is because there is hyperbaric therapy that helps in reversing the hypoxia and also consequently reducing the secondary consequences of vascular injury, including trauma and infection. Now, what are the unifying factors in this? Ischemia, edema, and also there is a gradient of injury we're going to talk about, and also reperfusion injury, and how to prevent the reperfusion injury. So if you see there is burns, threatened flaps, and crush injury, and compartmental syndrome, all these have a common source, like causing hypoxia and trauma. And there is a gradient of injury. There is a problem with ischemia, there is a problem with edema. All these kind of work together and cause problems with increasing hypoxia and tissue injury. Now, I'm not standing here trying to tell you that surgical principles are not the way to go. Surgical principles are the first way to go in this. Hyperbaric therapy is only a part of this whole picture. Now you got to do your revascularization, debridement, stabilization of fracture, antibiotics, tetanus prophylaxis, and fluid resuscitation. Now the pathophysiology of this whole process, including all the conditions with acute traumatic ischemia, include this problems with not getting good revascularization, and hopefully the revascularization will be established soon. Now, what happens when there is ischemia? There is the direct injury to the blood vessel. When this happens, there is flow that doesn't go through, and once that happens, there is external pressure with increasing compartmental syndrome pressure and stasis and vasoconstriction and occlusion. When this happens, there is increase in metabolic need for the body. And in the presence of ischemia, the metabolic need is more increased and the needs are not met, and that sets a nidus for more infection to happen. And edema is the second factor where we have to be careful. It could be because of vasogenic problem or cytogenic problem. There could be extravasation of intravascular fluid, and also there is increased tissue perfusion pressure and decreased intravascular oncotic pressure causing diffusion of the fluid out. And also, as the more the injury happens, the cell becomes hypoxic and then tends to lose water too. When there is massive edema, what happens? There is diffusion distance from the capillaries to the center of the cells. This decreases, and as it decreases, there is more increase in need of oxygen. If you see in this diagram, in the top is the tissue that has fluid that is a normal diffusion distance, whereas as the edema increases, the need for oxygen increases and the middle portion becomes more hypoxic. And the more the hypoxia, the more the problems. And as the pressure increases with edema, the capillaries in the margins shut down and cause more ischemia, and the tissue become necrotic. Now, trying to establish the classification is very hard because of the variation in the injury and also different kinds of injuries that we see. So acute traumatic peripheral arterial ischemia is comprising of crush injury, compartmental syndrome, burn, and a flap and a frostbite. So we'll talk about different crush injuries, and also we'll talk about the classification that I came across as I was preparing for this lecture, and trying to find the amount of tissue destruction is mostly done nowadays by a clinical picture. Okay, the surgeon, the clinician kind of thinks, okay, this is the amount of injury, but trying to gauge the amount is harder, and trying to use the different classification systems to get and make a quicker diagnosis and establishing an objective way to measure this destruction of the tissue would be helpful. So when there is, I'll talk about this Gustillo classification in a little bit. If there is a mild injury, if you have Gustillo 1 and 2, and there is compartmental syndrome, this pre-symptomatic, and also the moderate is symptomatic, and there is loss of function in the third one, in a very severe, when there is severe injury. When you come to the burn, there is second degree and third degree burns become very severe, and frostbite the same thing. We'll talk about the Gustillo classification in a little bit, and also there is another factor that is very much important. When acute traumatic injury happens, there is self-progression and perpetuation of the compromised tissue. And when this happens, there is irreversible damage that happens. And time is a major factor, and it plays an essential factor in the continuum of healing and continuum of tissue destruction here. Within 30 minutes to 2 hours, there is a hypoesthesia and paresthesia that start. And within 2 hours, there is muscle injury starting. And also, within 3 hours, there is post-ischemic swelling. And within 4 hours, there is myoglobinuria. And within 4 to 12 hours, there is ischemia that with muscle damage beginning to worsen. And also, after 12 hours, post-ischemic contracture sequelae happen. Now, how does hyperbaric therapy work? Hyperbaric therapy worked with direct pressure. Like I said earlier, pressure into volume is a constant, and there are other mechanisms, including hyperoxygenation, angiogenesis, antimicrobial effect, and also vasoconstriction and reperfusion ischemia. We'll talk about each one of them. When you place a patient in a hyperbaric chamber, there is 10-fold increase in the oxygen dissolved. So if you put them at 2.5 to 388, there is almost 10 to 15-fold increase in the oxygen. 500 to 2,000 millimeters of Hg of oxygen is into the tissue. And the diffusion distance of the tissue increases 4-fold. And why is this helpful? Because when there is diffusion distance that increases, there is more chance of the oxygen getting into the spot where your blood is not getting into. This can happen because there could be sludging of the red cells, and it helps with maintaining the viability of tissue, at least transiently, before further definitive interventions could be done. So in normal baric condition, if you see there is 64 micron normal oxygen diffusion around, but in hyperbaric condition, there is diffusion increases almost fourfold. And this helps with, as I was talking about, prevention of worsening of ischemic injury to the tissue. Now, we're talking about the vasoconstrictive effect. With vasoconstriction, one of the contraindications for hyperbaric therapy is a patient who is in acute CHF. So chronic CHF, well-maintained CHF is not a contraindication. Patients who are in acute CHF, you should not dive them. The reason why is there is peripheral vasoconstriction. But with this peripheral vasoconstriction, there is 20% decrease in the blood flow, but there is increased oxygen diffusion that compensates for the blood flow. The net effect being increased oxygenation and decrease in the edema. So in a patient who is in congestive heart failure, the patient goes into pulmonary edema if you put into hyperbaric chamber. This can happen with a dialysis patient who is a fluid overload patient too. So the mechanism by which ischemia reperfusion injury happens is by producing the xanthine oxidase that causes superoxide production. And also there is increased adhesion of polymorphonuclear leukocytes to the vascular endothelium, and in turn causing the free radicals and causing the free radical damage. So xanthine oxidase is the primary source for active metabolites of oxygen. And basically, if you see this, as the ischemia happens as you go down the pathway, ATP is there, and normally it is used to it is helpful for our muscle contraction. But as the ischemia happens, you get hypoxanthine, and then in the presence of xanthine oxidase and calcium, there is free radical production. Now, when you reperfuse the tissue, or when oxygen by itself can help in this process, causing oxygen-free radicals to form. And the way to do this is, if you put the patient in the hyperbaric chamber, there is lesser production of this. And it is postulated that what happens is, normally it is not even the crush injury, but the stretch of the muscle is thought to be causing the problem with, it is postulated that what happens is, normally it is not even the crush injury, but the stretch of the muscle is thought to be causing the problem with ischemia. Because what happens is, there is lipid peroxidation that happens with oxygen-free radicals, and the hyperbaric therapy prevents this lipid peroxidation, and primarily this is shown to be more helpful in different tissues, including brain and the liver also. And I was talking about polymorphonuclear leukocyte addition. What happens is, when there is CD11 and 18 protein on the polymorphonuclear leukocytes that bind to intracellular adhesion molecules on the endothelium, that causes more sludging and more stasis. And polymorphonuclear leukocytes release the toxic oxygen radicals, and then this sludging happens, and the stasis happens. That prevents healing and causes worsening of ischemia. Studies were done by Zamboni and Burris that showed that there is increased vascular stasis and leukocyte adherence that happens, but in a hyperbaric condition, there is production of nitric oxide in the tissue. And the nitric oxide by itself helps with vasodilatation, and also there is inhibition of CD18 function. And this causes the microvascular bed vasodilatation and helps with blood circulation. So there is more trend even in wound healing environment about nitric oxide use, and it has been shown to be very helpful because it is shown to help with platelet-derived growth factors, and also different growth factors are helped by the production of nitric oxide in the wound bed. So coming to the Gustio classification I was talking about earlier. Now, if you see the type 1 classification is a small laceration. Here, this slide emphasizes that the classification, Gustio classification, in the presence of use of hyperbaric therapy in a compromised host versus an uncompromised host, and where to use the hyperbaric therapy. In the first and second Gustio classification, it's only a small injury, and the patient is not compromised, you don't have to use hyperbaric therapy. Whereas as you go to 3A, where there is crush injury but there is adequate tissue, you don't have to use hyperbaric therapy or any adjuvant therapy to help with healing, whereas in a normal host, you don't need to. But when it comes to the impaired host could be anything. A patient could be diabetic, a patient could be smoker, they could be immunocompromised, there could be other conditions with fever, infection that are going on there, or the crush injury might have been so bad, you think you have done a good job at cleaning the wound bed as a surgeon, but then at the end of it, microorganisms tend to still stay as much as cleaning as you might do. And then when there is inadequate coverage, it is 3B of Gustio classification, and there is crush injury. When there is vascular compromise, though, it becomes imperative that in all the situations, you really need to use some adjuvant therapy, including hyperbaric therapy. So the second classification system that is used is called Mangled Extremity Severity Score, MES. It is in using point system, basically 1, 2, 3, 4 for skeletal and soft tissue injury, where depending upon how much energy is used there, and then the second one is limb ischemia, the third is shock, and fourth is age. Now, when it comes to this classification, if the ischemia has happened for more than 6 hours, if you get a score, you double it up if there is more than 6 hours of ischemia. And it is recommended that there is a primary amputation if the MES score is more than 7 or greater. But everything depends upon the clinical scenario, I guess, and the salvageability that the clinician feels at that point. At least by these usage of these two criteria, you will have objective measurement of where we are going, not just the clinical sense. Now, when it comes to compartmental syndrome, now there is a mnemonic 5 Ps, pain, paresthesia, paresis, and pulselessness, and paralysis. So all these 5 Ps are the criteria for compartmental syndrome recognition in a quick way. That's a mnemonic. But when should we do hyperbaric therapy when there is compartmental syndrome? At least presence of 3 of these: pain in the muscle compartment, discomfort with passive stretch. Suppose if you stretch a finger and the pain is there, yes, something is not good. And swelling and fullness of the compartment, hyperesthesia, and impaired or marginal host, hypotension, and prolonged ischemia. Now, on the top of using that, and also you need to add in pressure measurements, and if it is up to 40 millimeters in a healthy host, or 30 to 40 millimeters in an impaired host, or even 20 to 30 with a marginal or shocky host. And after you do fasciotomy, now if there is residual ischemic tissue, and if there is threatened flap, residual neuropathy, massive swelling, and prolonged ischemia, that is one of the, if any of these are present, hyperbaric therapy will help. And now, what is the clinical evidence? There is not much that we could bank on except one randomized control study. And there is Strauss et al. Have described some study, but mostly the clinical evidence is less because it is a daunting task to do a compared study in this kind of a scenario. And basically, this study was done by Strauss using 700 patients tracking different criteria, but it's like, I feel better after hyperbaric therapy. That's not a greater study, but that's what you got from the case series and reports using that. But then we have other studies where Stupak et al. Has a case series of 13 patients, and he has shown that there is 75% reduction in the trauma and acute ischemia injury with adjunctive hyperbaric therapy. Now, this Redonic et al. Did a study where they followed the army personnel who had injury to the popliteal vessel, and in patients in this scenario, they showed that most of the patients who had hyperbaric therapy fared better than the patients who did not have hyperbaric therapy. Now, Matos et al. In 1999 showed that the limb preservation in 23 patients who had hyperbaric therapy was better. Now, this was the random control double-blinded placebo study. This was the only study that is a randomized control study for crush injury done by Boucher. 36 patients were done, and they randomized with 2.5 ATA for 90 minutes and 1.1 ATA with air. And basically, they standardized the therapy, and his recommendation at the end of it is, in patients who have crush injury grade 3 or higher, in patients who are more than 40 years, it is very much helpful. Now, what are the protocols that are used? There are different protocols by using 2 to 2.5 ATA TID in the first day, then BID. Then I would say it's mostly how the clinical picture evolves. And there are different accelerated protocols and hyperbaric committee protocols, but it fairly comes down to aggressive hyperbaric therapy initially, then followed by the clinical picture after 2 or 3 days of treatments. Now, hyperbaric therapy does not supersede surgical principles like we talked earlier. It's just a part of the process that has to be taken along with the other clinical picture. But if there is a delay in the surgery, doing hyperbaric therapy sooner might not hurt. So at this point, I would say that there is role in hyperbaric therapy, and it is needed in people who is logistically, we can try to get them in, and sooner we get them in, the better it is. The idea of this whole talk is trying to figure out how we can get the process and the steps in place so that hopefully we can come up with a criteria to try to figure out how we can do a better job at it and try to prevent the patient that I was talking earlier who lost her limb, who possibly might have saved it, but I guess hindsight is always 20/20. What I really want to also talk to you, apart from crush injury, was the newer things that are going on in wound care and limb salvage things. We're trying to figure out, there are studies done in Europe that have shown, and in fact in Chennai, which is in India, 400 miles from my hometown, there was a study done in Europe and in Chennai where they took the bone marrow of the patient's from the iliac crest and spun it down and injected into the muscle. So these studies were done in Europe also, where they have used a CD34 fraction of the bone marrow mononuclear cells, which are injected into the muscle. And it has shown that there is increase in vascular endothelial growth factors, which is VEGF, and also basic fibroblastic growth factors, and also angiopoietin-1. And infusion of these cells has been shown to increase angiogenesis in the ischemic limbs. Now, the stem cells really, how do they, normally everybody, you, me, everybody have stem cells. Now, there is a difference between different kind of stem cells. We are talking about autologous stem cells, not somebody else's stem cells. So forget about the ethics, the morals of stem cell therapy. We're talking about your own stem cells. So stem cells are there in the bone marrow. They are there in the initial cord blood. So you should not be worried that you don't have stem cells just in case something happens. Nowadays, there is techniques wherein they can take your stem cells from the blood or from the iliac crest and bank them for the purpose down the road. So coming back to the talk, the issue is the stem cells have a role in wound healing. If there is efficient growth factors in the wound bed environment that could be injected, suppose using a platelet-rich plasma, you could inject a platelet-rich plasma around the wound into the wound bed, and what happens is that helps with the homing mechanism. The growth factors in the margins of the wound bed are increased. That helps with the homing mechanism of the stem cells. But what we are talking here is taking the stem cells from the bone marrow and injecting them into the muscle, and this is shown to be helpful in angiogenesis. Now, this is very interesting. So 3 or 4 days ago, I was just trying to figure out what else to tell you guys about stem cells or the newer therapies that are going down the road, and I found this news article, which is this was a study done in an enlarged heart. This was done, and it was reported on March 16, 2011 in Journal of American Heart Association. They injected stem cells into the heart that has shown that there is average decrease in 15 to 20% in the heart size, and this has been 3 times more effective than the current therapy for congestive heart failure. Now, see the amazing things and amazing times we are in to try to help different folks in different times. So what I would say is, as our circle of knowledge expands, the circumference also expands, and we need to know where we are ignorant, and hopefully that will open some windows. And basically, you see what you look for and you recognize what you know. Thank you very much.
Good afternoon, everybody. Some of you know me and some don't. I've been in the hospital here for 3 years now. I'm in charge of hyperbaric department and with regard to safety issues and regards hyperbaric oxygen therapy. Originally, I started by being a respiratory therapist and became board certified in hyperbaric medicine. At the same time, also certified by American College of Hyperbaric Medicine and National Board of Hyperbaric also. So it's a good thing for the hospital. Dr. Kamepalli has already touched on this of trying to explain what hyperbaric medicine is. Hyperbaric therapy is where a patient breathes 100% oxygen intermittently while inside a treatment chamber at a pressure higher than sea level. We do have three different types of hyperbaric chambers. You have the Class A, which is a multi-chamber. It can take up to 10, 12 people at the same time. We have Class B, which is just a single occupant. That's a mono chamber. And then we have Class C, which is just for animals only. And what we do have here in the hospital is the single human occupant, which is a mono chamber. As you can see, we do have a nurse sitting next to the patient, monitoring this patient. Patient in hyperbaric, we treat them with high level of FiO2 of oxygen. And it is a very, very serious business when you get them in there. And the critical time while the patient is in there is between 0 to 10 feet. That's when a lot of things could happen to this patient. They could rupture their middle ear. They could have barrel trauma to their ears. The reason being, like Dr. Kamepalli pointed out with Boyle's law, hyperbaric deals with Gauss' law, the Child's law, Boyle's law, Dalton's law, and the rest of it. With the Boyle's law issue, you find out that when you increase pressure around the body, you tend to squeeze air around places like our ears. So if you do not observe the patient critically to make sure that you're getting them to pressure safely or telling them how to do what we call the Valsalva maneuver, a lot of time they rupture their middle ear. And how will you know that? You see a lot of patients, they start pulling their ears or screaming, or when they come out, you look at their tympanic membrane, it has ruptured. And you don't want this to happen. So that is the very reason why you need to stay put between 0 to 10 feet and observe this patient just to make sure that you walk them through and get them to pressure safely. Now, while you're trying to get them to pressure, again, it's very critical that you talk to them, observe them from that point until they get to pressure. You pretty much will see signs that they're beginning to have trouble. And at that point, what do? Stop the compression. It's not to increase the rate or emergency vent the patient. Because once you emergency vent them, you pop their lungs, and then you got a big problem in your hand. So stop compression right there and try to stabilize your patient, because you're not trying to drive a super fast train. You're trying to get the patient to pressure safely. That's your very number one objective, to make sure that patient gets to pressure and observe that. The next thing I want to talk about, because a lot of things I want to talk about, is on safety. The National Fire Protection Agency is the organization that has written our primary standard, safety standard in hyperbaric medicine. According to the NFAPA standard, all patients are grounded in a mono chamber. The term grounding is the machine itself, the hyperbaric machine itself is grounded to the hospital system. But then you need to ground the patient, because you do not want any kind of static electricity shock while the patient is in there. So you want to make sure there's no kind of shock. And then we do that every day. You have to check the resistance and make sure that it does not exceed 1 ohms. If it's every furniture, everything inside the hyperbaric chamber is grounded. If it's above 1 ohms, please do not get the patient in there. It's very, very important that you check that grounding system every day. That's the more reason why when the nurses come to the unit in the morning, I usually ask them to synchronize the machine to 2 atmospheric pressure and check everything, make sure the grounding system. Probably last night, the cleaners came and they were trying to move things around, and they just touched one cable. And if you assume everything is the same way it is, then you got a problem. So always do your daily check before you get the patient into that chamber. The On-the-Sea and Hyperbaric Medical Society embodies the clinical practice of hyperbaric medicine in the United States. They are the ones that, in conjunction with Medicare, has approved indication. Unless you're doing what we call off-label. You stay on your own, you open up your own office somewhere, but Hyperbaric has been recognized by the Joint Commission. So if you are here in the hospital, you have to go by the guidelines of On the Sea and Hyperbaric Medical Society. If not, a lot of the things you do will not be paid for. The insurance will not approve it. Even if you think it's the right thing to do, you just have to go by that guideline. So a lot of time, because you see people bring things up from the internet and say, yes, this can go, and I've seen this. Sorry, that has not been approved. In case like the problem we had in Florida last time, you have a fire, anything, you'll be making money for the lawyer, because they will go back and throw this On the Sea and Hyperbaric Medical Society book in your face and say, who gave you the okay to do what you're doing? Then you got a big problem in your hand. Since we're around the wound clinic, assume that every patient that comes through the door has one problem or the other. I came up with an idea that regardless, once we get a patient in that chamber and bring them out, we need to clean that chamber outright. We need to use an approved strong alkaline solution, which has been approved by CCRIS to clean this chamber in case there are problems is somebody else that had going into the chamber. So we clean the chamber after every patient. So that way nobody will go in there and come out with problems or have acquired some bad jams. So we also check the toilet on each chamber daily. And if they have any problem, they report that to me. I've been trained on how to see to this problem, because if you don't find these problems, they can create serious problems. Once they see crack in the chamber, I need, we report that and follow the appropriate guidelines to make sure that it is taken care of. Again, like the oxygen because the problem, we've had this thing happen somewhere in the United States where they thought they were treating the patients with oxygen, but again, they were treating with bad gas. So what I've done is our oxygen that is supplied to us is sampled every day. It has to say on that paper by air gas, oxygen, 99% or 100% oxygen. If I don't get that on the paper, I'm not going to treat the patients with that, because again, you have to be careful of the gas you're using before you get into problems. So we check that out every day. So these are some of the agencies responsible for design and safe clinical practice of hyperbaric medicine. Compressed Gas Association, they are in charge of handling of compressed gas cylinders. The On the Sea and Hyperbaric Medical Society, they are in charge of the clinical practice of hyperbaric medicine. So they have the approved guidelines, what you need to do. What are those diagnoses that are okay to do and not to do? The National Board of Diving and Hyperbaric Medical Technology, that's where you get your certification after you must have taken your schooling, and then both physicians and everybody else, if you wish to, then you can take the certification test to be certified in hyperbaric medicine. The American Society of Medical Engineers, they are in charge of the material selection, fabrication, testing, and sampling of the pressure vessel. And any hyperbaric chamber that you have that does not conform to this standard, then you are looking for trouble. Trouble. So you just don't even touch